Hey everybody, welcome back to Spot Check. We're going to continue with the genoderms here and go over disorders of vascularization. As always, two med students here that have helped me get through this PowerPoint. That's Jeff and Paul down here. Give them a comment, throw them down below if you like them and they've been helpful to you in any way. Alright, getting on to it. So Sturge-Weber syndrome here. It's a high-yield disorder, also known as encephalo-trigeminal angiomatosis. Inheritance here is sporadic, but the GNAC gene is often implicated. And it's a rare subset disease in the already rare subset of patients that get capillary malformations. So just to put that in perspective, 0.3 to 0.6% of infants are actually born with a facial capillary malformation, and only 2 to 11% of those children actually have this disorder. So pretty rare. That being said, do need to know a lot about it because it can be devastating. So one of the first signs you see here is often seizures in a 1 to 2 year old, besides obviously the born with capillary malformation. One of the first signs of specifically Sturge-Weber you can see is the seizures, okay? And what we do know about this is that the pathology is due to defects in the morphogenesis of the cephalic neural crest. So therefore, you're going to see subsequent abnormal vasculature in the upper facial dermis and the choroid and the pia and the arachnoid matter as well. Read this graphic here from top to bottom, okay, not left to right, but here the skin manifestations, you'll notice capillary malformations, the trigeminal nerve distribution, unilateral, more common than bilateral, but bilateral can portend to a poorer prognosis, especially the other manifestations that we'll go over. We can also see a progressive soft tissue and skeletal hypertrophy under the malformations as well. CNS-wise, you can see capillary venous and arterial malformations, ipsilateral, and that's of the CNS, ipsilateral to the actual skin malformations. So the leptomeninges can have their own malformations, which is where you're going to get the neuro side effects from. You may also see cerebral atrophy, tram tract calcifications. That is a buzzword here. Tram tract calcifications in the temporal and occipital cortex beneath the leptomeningeal malformations. You'll often see seizures. You may even see intellectual impairment, hemiparesis, and headaches as well. In the eyes, you'll see choroid malformations, visual loss, ipsilateral glaucoma with secondary buthophthalmos. MRI is helpful here with contrast. PET scan can be done in younger patients. You might not actually see the secondary calcifications or manifestations readily on MRI, so just be aware of that. That might take a little bit of time to progress, but you can get an EEG early if you're trying to evaluate for that early sign CNS involvement. Management here for the skin, for the capillary malformation of the skin, you can do a laser treatment, a pulse dye laser. Of course, you're going to have to send out for ophthalmology, neurology, maybe even orthodontist or oral surgery because of maxillary hypertrophy, gingival hypertrophy, etc. But mainly your big thing here is neurology is going to have to control those seizures because that leads to the better long-term normal lifespan that you can see. Clinical pearls here. It's a minority of the minority, right? You can see atrophic changes, but there may need to be a little bit of time in between before the MRI is positive of those calcifications. You'll need to get an ophthalmologic exam. Seizures are often the most concerning part of this, but if controlled with anticonvulsants can obviously lead to a more healthy life. Rarely they do hemispherectomies for this, hopefully not too often anymore. And then you can initiate early pulse dye laser therapy for any type of facial capillary malformation. All right, moving on, Klippel-Trenaunay syndrome, also known as angio-osteohypertrophy syndrome. Inheritance here is also sporadic, but you'll see that the gene typically implicated is the PIK3CA gene. Typically, you see this more in males than females. Capillary malformation might be the first sign, but other signs are then to follow. Pathology is due to increased vascular supply, hypothesized as the cause of limb hypertrophy. Differential diagnosis is listed there. Skin manifestations, you'll see capillary malformations often being the first thing. You might see that in the lower extremity, less commonly in the upper extremity or combined. More often than not, you'll see this unilateral, but it's not exclusive to that. Musculoskeletal-wise, you'll see soft tissue, muscle, and bony hypertrophy below the cutaneous malformation. You may see an increased limb length and or girth. Rarely does the limb present with, but can happen: hypertrophy, polydactyly, syndactyly, vascular malformations. All of these, all the vascular malformations you know of as a healthcare provider. Do note that the one thing I want you to take away from this is that AV fistulas can be prevalent in this, especially with Parks-Weber variants of this syndrome. So, and that also can lead to some downstream effects too. So that's the one thing I want you to keep in your mind. You can have AV fistulas with this. Lymphatic malformations are also present with or without lymphedema. So Dopplers are actually going to be pretty important. Dopplers can help give you a idea if there's an AV malformation or what other vascular malformations are present. Of course, what does that better? MRI and MRA do that a lot better. Venography and lymphography can also be present as well. Compression wraps are going to be helpful. That helps with the edematous component, lymphedema, vascular malformations. You'll be congested with a lot of blood retained in usually the affected limb, which is usually the lower limb. You can also continually routinely measure limb length and circumference. You will likely need correction in some capacity. You'll need to monitor AV fistulas, because if you leave an AV fistula too long and it progresses, just like the limb length discrepancy will progress and all the other signs of this disease might progress, you can have high output cardiac failure. And also with a capillary malformation, you can treat it with PDL, the cutaneous version that is. So ultimately, put a compression garment on. Yes, they're going to complain, especially with those medical grade high pressure compression garments. Leg length discrepancies. If you have a greater than 1 centimeter in height discrepancy, you might need a heel lift or a leg lift. Doppler imaging is helpful. Do know if you do have a particularly edematous leg, you might be more disposed to distal foot bacteria, paronychias, warts, etc. So you could break down the skin a little bit easier, making you more susceptible to infections in the affected area. And this is going to overlap with Proteus syndrome, so we're going to talk about that in a few slides. Keep that in your mind. Try to keep these separate, okay? Cobb syndrome here, cutaneous meningiospinal angiomatosis, inheritance here is sporadic. I don't have a great gene to pin this down on, but it's usually equal in gender and assigned births. Neurologic complications present early in adulthood, and while the skin manifestation can be present, usually the first thing present, it's not exclusive to this disease, so you don't always see the capillary malformations with it. That being said, if you do see the skin manifestations, it's usually in the posterior thoracic lumbar limb. Vascular lesions, it usually follows the same metamer as the affected area of the spinal cord, but the CNS lesions is what takes the cake here. Compression, weakness, muscle atrophy, sensation loss below the compression, because you're going to have that fast flow vascular malformation, which can compress on certain areas of the spinal cord, leading to segmental deficits thereafter. If extensive enough, you could have bladder and sphincter dysfunction, subarachnoid hemorrhoid malformation, even involving a vertebral body if extensive enough. MRI, MRA, and spinal angiography are going to be awesome in diagnosing this, but this is going to be more out of the hands of the dermatologist and more in the hands of neurology and neurosurgeons here. So make sure you have that in your head as well. MRI is going to be the treatment of choice, or excuse me, the imaging of choice. Then you need to figure out how you're going to tackle these lesions. Are we going to embolize? Are we going to do some sort of corrective surgery? And I put this here just so I don't forget it. There is a specific name, eponym associated with a facial metamer and brain involvement. So it's basically Cobb syndrome of the head. That is Bonnet-Duchamp-Blanc syndrome. So that's basically you have a facial metamer, capillary lesion, or vascular lesion, as well as brain involvement. All right, Proteus syndrome, it's back. Don't get this confused, okay? Proteus syndrome can look like Klippel-Trenaunay syndrome. However, this is more of a inheritance that's sporadic, but with the AKT1 gene. Also implicated is the P10 tumor suppressor gene. So those are some things to be aware of. Equal and assigned genders here. Skin-wise, you're going to see soft subcutaneous masses, likely lymphatic and venous malformations. You're more likely to see lipomas in this. You can see capillary malformations. This one is more likely to see linear epidermal nevi, palmar plantar hyperplasia, and you can see some varicosities. Musculoskeletal hypertrophy, depending on what's affected, you can see asymmetric soft tissue growth, especially in the feet, hands, limbs, macrocephaly, facial asymmetry, skull hyperostosis, frontal bossing, syndactyly, kyphoscoliosis, and some ocular findings as well, cataract, strabismus, microphthalmos. You can even more rarely see testicular tumors and penile hypertrophy. And here on the right, you can actually see, which is more characteristic of this disease, Proteus syndrome, is plantar hyperplasia. Referral is going to be to those where the symptoms are dictating. So keep that in mind. I don't have a great list of these people need to see this person, in this exact scenario, but follow the symptoms on this one. Interestingly, actually, Joseph Merrick might have, the Elephant Man in history here, might have actually been considered to have Proteus syndrome rather than neurofibromatosis. Do note that the plantar hyperplasia is striking for this syndrome, and that there might be some manifestations that are so extensive surgical correction is too difficult. Moving on here, Beckwith-Wiedemann syndrome, also known as EMG syndrome. Most cases are sporadic. The KIP2 gene or P57 protein on chromosome 11 is typically implicated in this. The pathogenesis here is that protein is a cyclin-dependent kinase inhibitor, which acts as a negative regulator of cell proliferation. However, if a mutation of that inhibits its activity, then you have overgrowth of organs and increased susceptibility to malignancies. Omphalocele, notice that here on the right, you can have macroglossia, omphalocele. So other differentials are going to include things that have omphalocele here as well. Skin-wise, you're going to see capillary malformations on the mid-forehead, glabella, upper eyelids extending to the nose and upper lip in some cases. You may see macroglossia. Interestingly, you might see linear earlobe creases or circular depressions of the rim of the posterior helices. Everything can be omegalied, so hepatomegaly, splenomegaly, nephromegaly, pancreatomegaly, cardiomegaly. You can also see, like we talked about, omphalocele and even intestinal malrotation. You'll have a somatic gigantism. Birth weights and length will be greater than 90th percentile. You might even see a hemihypertrophy. And more commonly with this disease, you'll see neoplasms. So Wilms tumor, followed by hepatoblastoma, followed by adrenocortical carcinoma, rhabdomyosarcoma. And you typically see these more in patients with hemihypertrophy here. You'll want to get blood glucose levels. Blood glucose levels help because of the various organs involved, as well as routine, at least periodic intervals of renal ultrasound or abdominal ultrasound to see what organs are being involved. You could screen for hepatoblastoma with AFP levels as well. So monitor blood glucose levels. In fact, it's so important that if you have episodes of prolonged hypoglycemia, you might involve the growing brain of a child. So being aware of that, being a part of this is important. Pediatric surgery might need to be involved as well with the appropriate subspecialties. And these babies are large, but they normally lead a normal life as long as there's no neoplasms involved. So they're, otherwise doing well. Clinical pearls here, the phenotype is quite variable, so you might not see everything we talked about, but it's a good sign of things to look for. As always, severe neurologic sequelae may result from undetected hypoglycemia, so make sure you're on par with that. Microglossia can be evaluated surgically. Ultrasound can be done every 3 months for the first few years, and then transition every 6 months to rule out those embryonic tumors that are linked to those paternally imprinted regions on chromosome 11. All right, moving on here, we have von Hippel-Lindau syndrome. It's an autosomal dominant inheritance of the VHL gene on chromosome 3. Prenatal diagnosis, you can usually get this from DNA analysis. Incidence is around 60,000 births, and you don't actually see this too readily until the 4th decade of life. VHL is a tumor suppressor gene. Some findings here, and obviously we have the findings here on the right that you should check out here. Always feel free to pause the video, scan over these. I do tend to go over them in the later slides, but it's just good to see a graphic, right? So anyhow, moving on. Eyes, we can see retinal hemangioblastomas with secondary visual impairment, blindness if untreated. You can see cerebellar, or less commonly, medullary or spinal cord hemangioblastomas with secondary signs of increased intracranial pressure. So you'll see those signs and symptoms, or spinal cord compression with its associated signs and symptoms. More commonly in this disorder, kidneys can have renal cell carcinoma or cysts, so look out for that. Endocrine-wise, they can actually see a pheochromocytoma, pancreatic cyst, adrenal carcinoma. The reason why dermatology is talking about it is there are capillary malformations. Not the most common thing to present with this, but it can happen. So look out for capillary malformation that can clue you into this early on. And hematologically, you'll see polycythemia and that's secondary to cerebellar hemangioblastomas and renal cell carcinomas. And these renal cell carcinomas can actually increase your production of erythropoietin. CT MRI of the brain can help here. You can also do urinary VMAs, serum catecholamine levels, CBCs, etc. can be helpful. Management here, photocoags, cryocoagulation of the tumors of the eye can be helpful. You're going to need to see neurologist and neurosurgery, maybe a neurologist, depending on what all is involved, especially with the kidney involvement. You will have to likely see a urologist. And then the key here is to kind of extend your discussion, your evaluation to all first degree relatives. And that might be because of its later onset. So if you can more early start your screening, you might be able to prevent some of these longer secondary outcomes here. Premature death secondary to progressive growth of CNS hemangioblastomas or metastatic renal cell carcinoma is often the cause here, or concern. Clinical pearls. So you'll see a progressive, universally fatal disease with this, and death happens at the 4th decade. That's actually why it's so important to screen your other first-degree relatives for this. Hematuria is often a common presenting sign. You can screen with a sonogram of the abdomen. MRI, CT of the brain can help you find those cerebellar manifestations, calcifications. Eye exams annually are helpful. DNA testing for the mutation can be often available and indicated for screening of children of the affected patients. Angiography usually is performed preoperatively. If kidney involvement, these patients may be candidates for renal transplantation as well. AT, also known as ataxia-telangiectasia, you can see this also named as Lewy Bowyer syndrome. This is, and like the last one, VHL, we talked about autosomal dominant, and well, now we have an autosomal recessive gene, so we're out of the sporadic garbage, and we're back into more traditional inheritance pathways. Autosomal recessive ataxia-telangiectasia, mutated gene, ATM gene, here on chromosome 11 as well. Prenatal diagnosis via amniocentesis. You can also do a molecular DNA analysis, which is more the way of the future right now. Typically, you'll see this more towards the 2nd or 3rd year of life, and that's when your child begins to walk, and then the telangiectasias happen after. And that's pretty high yield, because sometimes they might ask you, which came first, or what's happening first. So typically, as a repeat, you're going to see it when the child starts walking. But the skin manifestations happen a few years after. Pathogenesis here, the ATM gene encodes for proteins important in DNA repair, especially after ionizing radiation exposure. The ATM gene activates via phosphorylation repair mechanisms utilizing the P53 pathway, and that regulates, obviously, apoptosis cell cycle. You guys remember that from medical school. So anyways, that's defective, and you have a defective cellular humoral immunity as well. You can also see, separate from this, but in a similar realm, progressive depletion of Purkinje fibers in the cerebellum. That's why you see the ataxia component of this. Other things that can be, in your differential when you see patients like this, you'll see HHT, generalized essential telangiectasias, or Bloom syndrome. Key features of ataxia-telangiectasia, so obviously the telangiectasias. You'll see this in the bulbar conjunctiva. Might even see this on the ears, eyelids, cheeks, neck, upper chest, flexor forearms. Sometimes you can have a progeric face, so decreased subcutaneous fat atrophy and sclerosis. Granulomas are actually found in this. Cafe au lait macules are actually found in this. CNS-wise, you could see, obviously, the ataxia, like we talked about at length last slide. Progressive nystagmus, slurred speech, ocular motor, apraxia, growth, mental retardation, intellectual impairment. Sinopulmonary, since you do have an immunodeficiency associated with this, you'll see recurrent viral and bacterial infections, as well as progressive respiratory impairment. Endocrine-wise, ovarian dysgenesis, insulin-resistant diabetes might be noted. Neoplasms here, lymphoreticular is the most common, obviously, due to the high replication rate of blood cells. However, breast carcinomas are also a common etiology as well. Here's a good example of a telangiectasia where it's not supposed to be. That's the ear. Other things you can see increased T suppressor cells, decreased T helper cells. Evaluate, you can see elevated alpha fetoprotein. Sometimes you can even notice certain IgGs that are decreased and or absent. Management here, you want to evaluate other family members as well. There are certain mutation types that can have you at an increased incidence of breast cancer and lymphoid malignancy, so it's necessary to catch those. Referral to hem-onc. Obviously, you might even do IVIG, as well as malignancy management, depending on what malignancy is involved. If it's more blood or, traditional solid tumor, anyways, oncology is going to be able to help out with that. Referral to palm, especially ID, you're going to have constant infections. Maybe they'll have a good prophylactic regimen. Referral to neurology for the ataxia and CNS side effects thereof. You want to avoid any type of radiotherapy, radiation, bleomycin as well, more commonly, and this is just because of increased mutation or increased issues or downstream effects from the ionizing radiation. Sun avoidance, obviously, sunscreen will help, and that can even help prevent some progeroid changes as well. Most patients are ultimately confined to a wheelchair at an early pediatric age, unfortunately. And then you have death secondary to some sort of malignancy or infection. Clinical pearls. So the major caretaker here is going to be the neurologist, obviously. However, it's going to be a collaborative approach. You're going to need to protect them from ionizing radiation, x-rays, UV, etc. They're going to be covered in sunscreen and protective clothing. You're going to have to look out for whatever cancer they're going to get, and then have hem-onc involved as well. Sometimes you can actually use radiotherapy to treat lymphomas, but the catch-22 obviously is that radiotherapy will cause other downstream effects as well. And there is a risk of breast cancer in female heterozygotes, so that's another reason why you want to make sure that you are screening relatives. HHT, also known as hereditary hemorrhagic telangiectasia syndrome. You'll also see it named Osler-Weber-Rendu syndrome. Autosomal dominant HHT1 gene or HHT2 gene. You can also see them named endoglin gene or the ALK1 gene. It's important to know, which subtype. So HHT1, that subtype, will have the endoglin, and then you're going to see other manifestations associated with that. The HH type 2, the HHT type 2 will have the ALK1 gene associated, and you'll see downstream manifestations with that. So you'll see this presents in early childhood to young adults with epistaxis in 50% of patients. You can see cutaneous GI telangiectasias, and that happens around the 30-year decade. Pathogenesis is due to that HHT1 or HHT2, like we talked about. HHT1 is endoglin gene mutation. That is a TGF binding protein on endothelial cells for angiogenesis. The HHT2 is a ALK gene mutation, which is another endothelial cell based regulator. Skin here, obviously, it's in the name, telangiectasias being hereditary. You're going to see them everywhere on the face, palm, soles, subungual region, ear, nose. You can see them on the mucosa. Epistaxis is going to be common. And then more concerning, you're going to have hepatic AVMs, maybe concerning for hemorrhage potential, or pulmonic AVMs concerning for pulmonic potential. And it's actually, you can actually narrow these two down. So the pulmonic manifestations are more likely in HHT1, where the GI manifestations are more likely in HHT2. Do note that CBC, chest x-ray, MRI, all that is important because you can help find AVMs that way. You can do a GUAC school if you think they're bleeding from some sort of GI issue. You can do endoscopy, obviously, is going to be more paramount if they're symptomatic or you have a evident blood loss. They're going to see all the doctors, obviously, for when they need them. If you have telangiectasias from a dermatologist perspective, you can get them lasered, but that's really, honestly, we're here to diagnose, and that's about it. Prognosis-wise, like I talked about, HHT1, pulmonary AV fistulas, HHT2, hepatic AVMs. And that's where the issues happen, right? It's those arteriovenous malformations that can then break down. All right, moving on here. Cutis marmorata telangiectasia congenita. Inheritance here is sporadic. The incidence is rare. It's present at birth. Pathogenesis may actually be due to an autosomal lethal mutation with ability to survive only in mosaic state. So that's something to be aware of as well. Your differential diagnosis here is capillary malformations, physiologic cutis marmorata. One way, I'll say this right now, I think it's in the slides later, but one way to differentiate CT or CMTC from physiologic cutis is that rewarming, actually, like warming the area, will make the physiologic cutis marmorata somewhat resolve, where CMTC will not resolve to warming. So that's just kind of a high yield tip there. You can also see this in Rothman-Thompson syndrome. In more chronic or more concerning lesions of CMTC, you can see atrophic reticulated vascular patches on the extremities, trunk, or face. You may even see, more rarely, ulcerations, phlebectasias, capillary malformations, localized, segmental, or generalized. If you're going to have associated findings, you might see them in 50% of cases of CMTC, and even in those subsets, you're going to see them more commonly in generalized CMTC. So other findings, musculoskeletal, you might see an ipsilateral hemiartrophy, hemihypertrophy of the extremity, limb length, and circumference discrepancy. Cardiovascular wise, you might see actually a patent ductus arteriosus or arterial stenosis. You could see glaucoma. You can also see MR. Management prognosis here. So management, you want to do a complete physical, obviously. Regular interval measurements of the limb lengths and the circumference to see when or if ortho needs to get involved. Referral to an ophthalmologist for evaluation. Skin lesions often fade within the first few years of life, which is good. And also limb length or circumference discrepancy may also improve with time. The most common problem is atrophy of the soft tissue, as well as the limb length discrepancy or leg length discrepancy. Do note that some people may have a reticulated form of nevus flammis or capillary malformation that is misdiagnosed as CMTC. The key here is that the nevus flammis, especially the reticulated pattern, is not as coarse, and the affected areas do not ulcerate, right? And just another thing I put here, so I don't forget about it, Adams-Oliver syndrome. That's when you have CMTC, aplasia cutis congenita, and transverse limb defects. It's a rare subset of the subset as well. Moving on here, we have Maffucci syndrome. Inheritance here is sporadic again. Incidence is rare. Genes implicated are IDH1, IGH2. Around 100 cases reported. It's probably grown a little bit since that literature was published. You'll see this in early childhood, and it may reflect a autosomal lethal mutation surviving in a mosaic state as well. Differential diagnosis here, Ollier's disease. And the reason why that's important is Ollier's disease has endochondromatosis without venous malformations. We'll talk about that a little bit in the future. Blue rubber bleb and Proteus syndrome. So what you'll notice here with Maffucci's is you'll have superficial and deep venous malformations increase on the hands and feet, but can occur anywhere, and they're asymmetric. You'll also see potentially venous lymphatic malformations, but these are less common. The key here is you'll also see endochondromas, which are benign cartilaginous tumors increased on the phalanges, long bones, and can occur anywhere. They're usually asymmetric. They can cause secondary fractures and limb lengths discrepancies as well. They can happen in the cranium and the vertebral column, so just be aware of that. And those causing neurologic sequelae can also cause short stature. Now, when you have this proliferation of endochondromas or enchondromas, you'll see obviously a potential for chondrosarcoma within them, so be aware of that. You'll want to do x-rays and bone biopsies to help evaluate and diagnose those more hard tissue bony abnormalities. And of course, physical examination, radiographic evaluation is helpful. Orthopedists are going to take the lead on this one, and you can send them to dermatology or plastics depending on the severity of some of these venous capillary malformations and where they present. So ultimately, orthopedists take the lead here. Because the bones are brittle, exercises should be like low weight bearing exercises, like not strong, like full weight bearing exercises. If they do develop an angiosarcoma, those are usually severe enough that they often are fatal, so be aware of that. Even though chondrosarcomas are more common, angiosarcomas can happen. Moving on here, blue rubber bleb nevus syndrome. Inheritance here is sporadic. Incidence is rare. Impacts everybody's assigned birth equally. Presentation is at birth to early childhood here. We don't have a great evaluation here of the pathogenesis, unfortunately. And the differential includes Maffucci syndrome, diffuse neonatal hemangiomatosis, Fabry's, and multiple glomus tumors. Skin-wise, you're going to see multiple venous malformations, which are basically these soft, dark blue, compressible, variable nodules on the trunks and extremities. Can potentially be painful, but not exclusively. Can also maybe have increased sweat over the lesions, but not exclusively. You may develop more lesions with age. You might also have a combined lymphatic venous malformation. These malformations are not exclusive to the skin. You can also see them in the GI tract as well. That can cause secondary hemorrhage or anemia. Other viscera can also have these venous malformations, but this is by a case report basis. Endoscopy, MRI, CBC, and school guaiacs are all helpful in this. Mostly look out for the GI secondary pathology. You can do surgical excisions, especially of the skin, venous malformations. CO2 lasers can also be helpful. That's more of an ablative laser type. You can screen for GI tract involvement with the stool guaiac test. If you have an anemia, you can control it with iron supplementation. If it's just a slow, just mild irritation bleed, ultimately will need to be seen by GI and surgery potentially. You can have a normal lifespan if you're adequately monitored, but venous malformations will still persist. It can be difficult to differentiate this from multiple glomus tumors, so be aware of that as well. If lesions are superficial, they may improve somewhat with PDL, but usually they're thick enough that you need a surgical excision or more ablative therapy. There's a potential that these lesions can recur after excision. You may not see gastrointestinal lesions with your MRI or your X-ray, obviously, so endoscopy is going to be paramount in that. You can also see intussusception depending on the types of vascular abnormalities you find within the gut. Also, not exclusive to the GI system or the skin, you can see other organs involved, like we talked about, so the CNS lesions might be present as well. Kasabach-Merritt syndrome here, inheritance here is sporadic. There's no prenatal diagnosis that's typically helpful, unfortunately. There's around 200 cases reported, more female than male here. Present usually from birth to first few weeks is when it's first noticed. And the key here is the pathogenesis is due to consumption coagulopathy within a caposiform hemangioendothelioma or tufted angioma. And that platelet consumption in that lesion is going to be how you uniquely treat it and what things you need to avoid, etc. So skin-wise, you're going to see large, rapidly growing, tender bruising, reddish purple, soft tissue papules or vascular masses with purpura. Most commonly, the vascular tumors include, like we talked about, caposiform hemangioendotheliomas or tufted angiomas. You can also see this with the lymphatic malformations. Also, petechia, ecchymoses. Usually the tumors leave a residual stain if they self-resolved, as well as fibrotic plaque, papules, or swelling. Hematologically, you're going to see a thrombocytopenia, microangiopathic hemolytic anemia, disseminated intravascular coagulation if severe. You might even see an acute hemorrhage in other organ systems, especially if you're going to see some of these other more concerning hematologic concerns. Cardiac-wise, you might see CHF here. The completed blood count's helpful, gets you an idea of where your platelets are at. You can also look at the coaguloscopy or coagulation cascade from a lab perspective and see what's all involved, if you're retaining these coagulative components or not. Management here often is initially done with prednisone. Some other treatment methods have been experimented with, such as vincristine and interferon alpha. Typically, you're going to send them straight to a pediatric hematologist because they're going to need to potentially do infusions of fibrinogen or fresh frozen plasma. But you really want to avoid platelet transfusions only if they're actively bleeding somewhere. And why is that? Because you can have so a lot of this is a platelet sequestration within those KHEs or tufted angiomas. So adding more platelets might make more platelets go sequestered in that lesion, causing it to enlarge or worsen the condition. But obviously, if there's an active bleed and you need the product, you have to give the product. Referral also for pediatric surgery for embolization or surgical excision, pediatric cardiology if there's a concern for CHF, or to monitor for that propensity as well. Diffuse neonatal hemangiomatosis here. There's a synonym. You have a couple synonyms like benign neonatal hemangiomatosis, multiple neonatal hemangiomatosis. Inheritance here is sporadic, typically seen more in females. We don't have a good idea of pathogenesis. You can see this on the differential with blue rubber bleb nevus syndrome, Fabry's, and multiple glomus tumor syndromes as well. Skin-wise, you're going to see 0.2 to 2 centimeter hemangiomas, multiple of them, generalized distribution. Viscera can be involved when you have, I believe, more than 5 hemangiomas of any size. You want to start screening for hemangiomas of the viscera, most commonly liver, lungs, GI tract, and CNS. So liver hemangiomas specifically may be complicated by hepatomegaly, obstructive jaundice, portal hypertension, hemorrhage, thrombocytopenia, anemia, and can cause a high output cardiac heart failure. High output heart failure may occur with or without the visceral involvement. You could do a skin biopsy to confirm your suspicion of a hemangioma. Liver ultrasound, like I said, if you have more than 5 or even a remote concern of this, liver ultrasound is an easy, benign thing to do to screen for the liver issues. If you're truly concerned further, you can do abdominal head, CT, or MRI. Abdominal head, chest. Chest x-rays can be helpful. CBC coagulation studies, school guaiacs, and urinalysis with hematuria, where you're at least looking for hematuria. Management here, much like the last, prednisone, vincristine, interferon alpha, especially if you're symptomatic. You might be a better candidate for interferon alpha. Some people use digoxin or diuretics if you're in CHF. You can also surgically treat any internal hepatic artery ligation, embolization of those hemangiomas. They're going to need to see the Justice League of specialists here, including GI, cardiology, surgery, pediatric ophthalmology. There is a concern of high mortality if visceral or liver involvement's noticed, secondary to concerns of causing a congestive heart failure that's high output, a hemorrhage, making infectious potential more possible. Ultimately, you'll see that these undergo a spontaneous regression. All right, moving on, we have face syndrome here. Face syndrome is, a mnemonic for something here, so we're going to go over that in detail. Face posterior fossa brain malformations, that's the P. Hemangioma for the H. A for arterial abnormalities or anomalies. C for cardiac anomalies or coarctation. And E for eye abnormalities. You can often add an S, faces, for sternal clefting or supraumbilical raphe. This one is an X-linked dominant transmission, so usually males will die with this. It will not even be successfully birthed, and you'll see mostly females or your occasional Klinefelter patient with this disease. Your first trimester ultrasound can pick up often these early structural defects. Incidence here obviously is rare, but obviously is going to be more female than male. You might see a few males with it, but mostly X-linked dominant transmission here. Pathogenesis is typically unknown, but some sort of developmental error that is noticed at 6 to 8 weeks gestation. Skin manifestations, you're going to see large facial plaque-like hemangioma in the region 1 or region 3, and we'll go over what those regions mean. Usually it's unilateral left-sided, more common than right. Can also see bilateral. More extensive lesions have greater CNS impact, obviously. Ulceration can also be seen in sternal clefts, pits with a supraumbilical raphe, and that's obviously the S in Facey syndrome. Central nervous system involvement, you can see posterior fossa malformations like a Dandy Walker malformation. You may also see hypoplasia, agenesis of the cerebellum, cerebellar vermis or corpus callosum, as well as abnormalities or anomalies of the internal carotid or cerebral arteries. These all present with secondary CNS issues like developmental delay, seizures, contralateral hemiparesis of the brain, etc. The C, obviously in face, is coarctation or cardiac anomalies. So you might see coarctation of the aorta or anomalies of the brachiocephalic trunk. So be aware of those. I as well, ipsilateral to the cutaneous lesion. ipsilateral microphthalmos, optic atrophy, optic nerve hypoplasia, may even see cataracts, increased retinal vascularity, etc. So here's the regions. They recategorize us. No longer are we going with trigeminal distributions, etc. So do note here four regions here that hemangiomas can develop that are described. Thanks to plastic surgery key here for letting us borrow this modified image here. Do note that the S1 and the S3 regions are more commonly associated with Facey syndrome. S1 specifically has more concern for brain involvement or ocular involvement. S3 has more concern with cardiac involvement, sequelae. You can get cranial ultrasound, MRI, MRA, aortograph, or echocardiogram as well. And, once dermatology evaluates and treats or helps treat the hemangioma, they're obviously going to see the specialists for the sequelae. So neurology, cardiology, ophthalmology. Clinical pearls here. First, when you see this, be on high alert. There might be some secondary sequelae. You're going to have to do an evaluation of infants at risk. So, and it depends on your clinical scenario and all that garbage. But ultimately, everybody should be getting evaluated, doing a hefty cardiac eye neurologic exam. That will guide your referrals and how you're going to send these guys off. It doesn't hurt to get imaging. So MRA should be attempted on anyone at risk. But there is that risk, obviously, of giving a child general anesthesia. So if you don't see neurologic signs, depending on the provider, you might avoid doing this more aggressive testing because there is some concern about general anesthesia in the young developing brain. So up to you. That's why a thorough physical exam is paramount, but some things to keep considering as well.